Okay, well, I'll start introductions while people continue to jump on. Today, I'm delighted to introduce Dr. Panwar and Dr. Xia, who both have topics in cancer research, different topics, but both in that field. And they have projects in development, so I'm confident that they're each going to be interested in getting some feedback and discussion and collaborators, etc. You know, students interested in joining, all of that. During the talk, if you have an urgent question, throw it in the chat, and then after each one of them is done, feel free to unmute and ask a question or raise your hand, or also put it in the chat, and then we should have plenty of time for discussion in this hour. I just want to mention also before we get started that we have two infectious disease related talks next month, April 28th, and then neurology, epilepsy focused in May. So come join us, and if you have an idea or a suggestion or would like to speak, please send me or Brianna an email. And I think that's all the introduction.
Recording in progress.
The only introduction we have. So I will welcome to you all. It's nice to see the faces now a little bit. We'll turn this over to Dr. Panwar, who's going to be our first speaker. Thank you for joining us.
Thank you very much. And I'm glad to be here, and I'm certainly grateful for the collaborators of interest that we have invited, especially to this meeting. Dr. Ramaswamy has joined as well, so thank you for doing that. Can you see my slides okay now, Brianna? Okay, and you can hear me okay? Sounds great. I have a couple of different project proposals that we want to discuss today. We are the head neck surgery team affiliated with Creighton. Our primary practice location is at Methodist, but we are well integrated into the residency training program and the medical school education plans as well. My first proposal that I wanted to discuss is a proposal for depression prevention trial in patients with head neck cancer. This is an area of great interest for us, and we have published a fair amount, including the results of a randomized controlled clinical trial in 2013 called the PROTECT trial, which was supported with an R01 funding grant from the National Institutes of Health. Let's see if I can, there we go. I do not have any conflicts of interest. I hold these dual appointments, and my contact details are listed there. Depression and head neck cancer is very, very common. A lot of it is driven by psychosocial determinants. The treatment of head neck cancers, the disease itself, affects speech, eating, and appearance, which is how we relate to our external world. As a result, our patients often have psychosocial distress and often depression as well. Our patients oftentimes have shared etiology in the sense of tobacco and alcohol use and substance abuse oftentimes. The treatments for head neck cancers can be prolonged. For example, radiation lasts many weeks. Many treatments are very aggressive. And all of this can lead to a frayed view of self and our relationships to the world. Nearly 1 in 4 patients with any cancer may experience depression, but in head neck, the risk of depression is as high as 50% of patients who experience head neck cancers. It is under-recognized as a problem, oftentimes because there are other pressing needs regarding physical health that the patient may be more concerned about. Depression-related issues are associated with poor quality of life in patients with head neck cancer. They have poor compliance with therapy, increased use of inpatient services, and increased cost of care. These two studies that I'm quoting here also indicate that patients who have depression have higher incidence of treatment failure, poorer overall survival, and disease-free survival. The SEER data that is quoted here, evaluating over 3,400 patients, suggested that 18% or so patients had depression concurrent to their diagnosis of head neck cancers, and they had a 38 to 49% greater hazard for cancer-specific mortality and 40 to 50% higher hazard for all-cause mortality. So these are significant numbers, and therefore it deserves a great deal of attention. There's also increased risk of suicide amongst patients with head and neck cancers, particularly those who are affected with laryngeal squamous cell carcinoma or hypopharyngeal squamous cell carcinoma, and those who are treated with incorporation of radiotherapy compared to primary surgical therapy. The adjusted relative risk for incidence of suicide compared to other cancers is roughly twice the baseline rate. Despite this recognition that depression is common in this patient population, less than 1/3 of severely depressed patients are clinically identified, and those who are identified, a majority of them are inadequately treated. So the idea of reacting to the diagnosis of depression doesn't seem as attractive, and certainly the event rate is so high that intervening for prevention may be important. Oftentimes, recognizing depression can be hard because the symptoms relating to depression and the symptoms that emanate from use of chemotherapy and radiation therapy that relate to fatigue, being withdrawn from activities, lack of energy, sleep disturbances, they're often very similar, so it's very difficult to parse out what's causing what. There's also this focus on the physical manifestation of disease. Patients want to see survival outcomes. They're less concerned about what's happening to their speech, swallowing, and their psychiatric or behavioral health findings. There's also the shortfall of integrated specialists, particularly from behavioral health in cancer care teams, and we see this in the real world in our cancer center and across the nation as well. So those are some important considerations. Ideally, our utopia would be that everybody plays an equal role and holds hands as we go along taking care of our patients. But as you can see on the right side of this panel, some specialties take outsized roles in the management of patients with cancers, particularly head and neck cancer, and the role of other subspecialties sometimes becomes deflated compared to the other ones. In recognition of this, our clinical team had performed a randomized control trial. This is the R01 supported randomized control trial evaluating placebo versus prophylactic antidepressant using escitalopram in about 125 evaluable patients in 2013. The results were published in JAMA Otolaryngology Head Neck Surgery, and we basically did not change the treatment paradigm for patients with head and neck cancers. These were stage 2 through 4 squamous cell carcinomas of the head and neck of varying anatomical subsites within the head and neck. And these patients were initially screened for depression. If they had depression, severe depression, they were not included. And throughout the course of the study, they were followed for depression symptomatology. When they developed depression, they were taken off the study and they were referred for appropriate treatment. But patients who did not develop depression during this course, they were provided prophylactic antidepressant for a total of 16 weeks, initiating with 10 milligrams of escitalopram or matching placebo, and then escalating to 20 milligrams 1 week later, and then tapering it down towards the end, and then following them for 11 more weeks after the 16 weeks of the therapeutic trial. In these 125 evaluable patients, we saw a 50% reduction in risk of depression. This led to improved quality of life for non-depressed patients, and the number needed to treat for avoiding one severe depression episode was about 6.8, which compares favorably to many other prophylactic strategies in head and neck and other medical fields. So what we're proposing here is an expanded clinical trial. Some of the criticisms and some of the feedback that we have received over the course of the years since the publication of this, and we've done some additional work, including secondary analysis of this clinical trial and other SEER and NCDB-based studies. What we've learned is that there's also interest in not just prophylactic antidepressant, but other forms of therapy such as cognitive behavioral therapy and supervised exercise. There's some parallels for supervised exercise, for example, in breast cancer literature as well. So we hope to expand on this knowledge, and what we want to do is to expand the options for our patients and see what works best for them. And we want to do a multi-center randomized control trial with multiple arms with an intention to treat analysis. Our hope would be that head and neck cancer patients would be randomized into one of these 4 treatment arms. And certainly we are open to additional feedback to further include or exclude specific arms or refine them as we develop this project some more. The primary outcome of interest would be incidence of severe depression. Previously, we have had experience using QIDS SR, a self-reported tool, or PHQ-9. The secondary outcomes of interest would include quality of life outcomes and adherence to treatment arm. For example, I'm very concerned that many patients who are undergoing intense head and neck cancer therapy may have a difficult time accessing cognitive behavioral therapy, even if they were to be randomized to that, because many of our patients live out west and they don't have access to that, or that they may not be willing to perform supervised exercise because of their personal motivations or physical manifestations of the disease and its treatment that may limit their ability to participate in such exercise programs. And that's why the prophylactic antidepressant paradigm seemed to be the most attractive one to us, given the small number needed to treat. But certainly these avenues need to be tested against each other to have definitive answers. Additionally, we would like to look at survival outcomes based on intention to treat analysis. I certainly would think that a crossover model would also be possible for these patients. For example, if somebody gets randomized to supervised exercise, if they do not pursue that, can they cross over to a different arm, and how does that affect their overall experience? The partnerships that we're looking for is the Department of Psychiatry, Biostatistics, and Health Metrics. As I mentioned, we invited Dr. Ramaswamy and his team to join us today, and I'm thankful that he's here. The Head Neck Oncology team at Creighton and Methodist Affiliated Treatment Service. We have what's called the Midwest Head Neck Cancer Consortium. It's a group of 6 institutions that collaborate on research related agenda items. And in fact, we have our regional meeting coming up here in about 5 weeks. The American Head Neck Society and many of us on the head neck team at Methodist hold office positions within the American Head Neck Society. In fact, my senior colleague, Dr. William Lidditt, who led the initial clinical trial, will be the president-elect for this society. So we have the opportunity to put the weight of the society behind it. And I'm hoping that we can gather some mentorship and guidance from your team in terms of gathering state grant opportunities, or there are precedent for NCORP opportunities, or potentially industry partnership if we were to look at matched placebo with Abbott Pharmaceutical, who makes the escitalopram, for example. So that's kind of the summary of what I wanted to present for the depression prevention trial. And I'm open to feedback and suggestions and thoughts about feasibility of this and interest in partnering with us on some of these avenues. So I'll pause here for a second before I present my second idea, and that will be a shorter one.
Yeah, thank you, Dr. Panwar. And go ahead.
No. Go ahead. I was just going to invite questions. So please go ahead, Dr. Ramaswamy.
Yeah. So, my question to you is one, and I'm ignorant in this area. Well, I know the effect of so in patients with depression and anxiety, there is sympathetic predominance, over the parasympathetic dominance, right? I mean that's why we see. You see just across. You see all the symptoms of depression, anxiety. It's all because of sympathetic overdrive, right? I mean, you ask patients, at least when I see my patients, that the sympathetic hijacking of the brain. I mean that causes a lot of issues. So with head and neck cancer, is there any I guess how to word it? I know the vagus nerve is not too far away, it's in that same area. So is there data? I can see where these patients would have a higher risk given maybe the prognosis and the impact. I mean, self-image and a lot of things, like any diagnosis. But does that have any effect on the vagus nerve? Because I'm very curious about it, because we tell our patients all the time, the treatment for anxiety, depression is, you really want to bring in that parasympathetic dominance. If you can, that's great. It's across the health. I mean, not just for depression. It's good for us. But is there anything in particular with head and neck cancer and parasympathetic or sympathetic overactivation?
Yeah, I thank you for your question. And I have recently seen some reports, including I think there's a clinical trial, a small clinical trial on vagal nerve stimulators for depression, intractable depression, at one of the sites in the United States. But that is not specific to head neck cancer. In general, we don't measure vagal activity for most patients in clinical practice. But if I were to use a surrogate marker, which is their vocal cord function, generally speaking, their vagal activity is preserved. So it's not very common unless there's direct invasion of the tumor into the vagus nerve or something of that sort, that they have vagal hypofunction or something of that nature, at least not measurably that we have seen. And we are only using surrogate markers, for example, vocal cord function.
Right.
So.
Okay. That's helpful to know, because I'm always curious if there's a particular condition that would actually cause more sympathetic overdrive, and the other comment I had is, of course, I think the prophylactic antidepressant therapy, there's data to show that it works, and that definitely should be included in one of the arms. My thoughts about CBT, and again, CBT is a gold standard for depression, but CBT has been around for a long time, and we still have patients. I have patients that come tell me they have spent, hours, 100 hours of CBT, and they still are not feeling any better. They know that. These are high functioning folks. You know what I'm saying?
Right.
So, and this is kind of maybe new to the field, but I've talked to people about it. It is. I think sometimes CBT, it's certainly useful, but in some cases, it actually can increase rumination, awareness of your negative thoughts, which may not be good. The premise of CBT is you challenge your automatic thoughts, right? You see for the evidence against it, and you try to, restructure that into more, rational thinking, or, so I feel that there are certainly, groups of patients that would benefit from CBT, but, when you're talking about a serious medical illness where there is a big amount of unknown, you just don't know, what treatment's going to do, the prognosis, depending on CBT. There's actually another form of therapy. It's called ACT therapy, acceptance commitment therapy. So, it may seem like a paradox, but in ACT, the goal is not symptom reduction. So when I tell this to my patients, they're surprised. They're like, "Why are you telling me this?" Well, the goal is not symptom reduction here. The goal is accepting that, one, that you have a diagnosis that's, it's a serious diagnosis, depending upon what stage, there's so many unknowns, right? So that acceptance piece, I think, sometimes gets missed. And people, if they just jump into CBT, they sometimes feel like, they're talking themselves into feeling like everything will be all right, with CBT, which is not the case. Which the reality is no, right? You just cannot say that, no matter how you twist and turn it. And then they give up. And plus, it is manualized, meaning, there's assignments. I'm thinking this group of patients just don't have the time, energy, even maybe concentration, effect of drugs to really engage in that kind of therapy. It is pretty manualized, and you have to do assignments, and lots of patients that drop out, they just say that, I can't do it, and they may put this at the back burner, saying that, let me focus on my next chemotherapy appointment, next appointment, Dr. Panwar. You know what I'm saying? Absolutely. So the CBT gets, so you may not get, so I haven't searched the literature for, I know with chronic medical illness, which we see a lot, depression with chronic medical illness, ACT or acceptance commitment therapy actually works really well. And you tell the patient that the goal is not symptom reduction right away. The goal is acceptance. And I think what that leads to is accepting that you have a condition, right? No fault of the patient. It can happen to any one of us, I guess, on the Zoom call. But then once you accept that, your emotional reaction to that, this is the way I tell my patients, you kind of downgrade that from feeling sad, unhappy, or well, unhappy is okay, sad, despondent, hopeless, to, a more realistic human, response that very unhappy, whatever, annoyance, you kind of downgrade the emotional response. I mean, that's the whole way ACT works, because those thoughts will not go away. And I tell my patients, it's just not going to go away. That is just asking for too much. I mean, and we all know that, the more you fight these negative thoughts, the stronger they get.
Absolutely.
It is a losing battle.
So I think the reason that I say CBT here, we had received, but theoretically we could also turn it into behavioral therapy of therapy and patients shared decision making / choice, and that could give us some leeway in terms of saying we're comparing a drug arm to a behavioral therapy arm to a placebo arm to a supervised exercise arm, and that's kind of the way that I foresee that we could mitigate some of those choices. Do you think that would be an approach that
that would be an approach?
Yeah.
But also look at ACT, and I'll over the weekend I'll Google and see. I'll go to PubMed and see if there's anything that's been looked at, especially in chronic medical illness. That's really the approaches we take anymore. CBT, certainly works, but one size doesn't fit all. And for some people, I've seen it makes things worse. Because you want these patients to distance. What you want is for them to get further and further away from these thoughts, right? The negative rumination, it won't go away. You tell them very bluntly, it won't go away. But, if you can put them, instead of being at the forefront, if it's at the back, I think you feel better about it. The supervised exercise, of course, there's a lot of data. I mean, I personally think, that's a great way to, prevent and combat depression. And I think there's more data for a group format versus individual. I think group exercise, there is more evidence, for, in depression. But, ultimately, I'll tell you, this is from my experience, over the years, and you ask your patients, if you take time, the thing that really is the elephant in the room is anxiety. Patients tell me that they can deal with depression, they can deal with, even psychotic patients can deal with hallucinations, but the sympathetic hijacking of your brain, that panic attacks, the constant worrying, that is something that they just can't. It's a losing battle. They just cannot. The more they try to get, on top of it. So the SSRIs, I think Lexapro. Were you thinking of the Lexapro, or were you thinking of a different agent?
Yeah, that's the one that we currently use in our clinical practice based on our findings from the clinical trial. That patients who are at high risk, we prescribe them Lexapro. But we want to have further external validity, because while some individuals and some institutions have accepted some of these findings from the only clinical trial that has been done in a randomized fashion in head and neck, there are others who are skeptical, and rightfully so. And that's the intention of this trial that we're designing.
But why wouldn't you? So this is, we, like, for example, a condition of PTSD, we have 2 approved drugs from the FDA, just because nobody's looked at other SSRIs. They pretty much all work the same. I mean, there's really not, there's differences, but is there any merit to looking at? Because I'm thinking these patients, there's definitely depression, which you'll capture by the PHQ-9, the QIDS. Is that what you were proposing? I forget.
Yes, QIDS are
okay.
Self-reported.
Yeah, I would throw in, really, I think you should throw in a scale that specifically measures anxiety levels, because depression is invariably comorbid with anxiety. It's just different proportions. Okay, so some people with, predominantly depressive symptoms, less anxiety, some just the opposite, just the other way. So in patients with more anxiety, you treat the anxiety effectively, the mood improves. They have more confidence, they can go out, they can socialize, they can do a lot of stuff. So I think it would definitely make sense to add a scale that, like the HAM-A, or there's HAM-D for depression, the HAM-A would clearly capture that. So if you ever thinking of using maybe another drug, just adding to the literature, not just Lexapro. I mean, there are drugs that, possibly treat anxiety, more effectively, I think. But again, there's so much variation among patients. But you're fine. You could just go with Lexapro. I'm not saying that because there'll be minimal drug interactions. I think that's one
Correct.
benefit.
Yeah.
That's the key reason. But even with venlafaxine and other drugs, there's hardly any risk of minimal risk of drug interactions. But I think, and then the placebo arm, I don't know what the placebo response rates were in that study, the one that y'all conducted. But mind you that there is, that's a big problem in psychiatry. Placebo response is pretty high. Believe it or not, there are many drugs that have not seen the light of the day, just because they're never separated from placebo. So, but it's good to have that. I think it's important for the clinician to know. But I would say, yeah, I think it looks, as from the department, we would be definitely interested to participate. Certainly, you have the patients, with the diagnosis, and we have the experience and expertise when it goes to, using some of these scales, self-report scales. I think the PHQ-9 is, the QIDS is self-report, but I think a clinician-administered scale is equally important. I think,
Sure.
There's merits to having both. So you could, but again, I think finally it's a trade-off. You don't want to make it too onerous, too time-consuming for these visits, because they have other appointments, chemotherapy, and you name it. But no, I think this is great. But my advice would be to look at ACT. It is out there. There's it's time tested.
Sure.
And then
I think, I'm glad that you have interest in this, and my hope is that I'll attend one of your research interest group meetings and present this to your overall group as well. And maybe we can think about working together with you or any of your mentees in developing a more expanded research protocol that we can then take not only here, but also to other institutions. And maybe we should start looking at potentially funding opportunities and even a grant application. That would be my hope if you guys are interested. And I would hope that Dr. Hansen and her team would offer us some support if they find merit in this.
Yeah, absolutely. Yeah. Are you thinking, I'm sorry, I missed, are you looking at a PA or RFA in particular? Do you have in mind something?
Yeah, so our experience in this, we are clinicians. We do a lot of clinical research, but we don't do a lot of bench research or NCI/NIH based research. This initial trial was an R01 grant, but we did require a lot of support from others who may have had experience. So I would look for some mentorship in that area. But my hope would be that NCORP funded trials would be the way that I was thinking about it most likely, just because there are NCORP studies that mimic some of this in breast cancer, and it seems like a priority for the NCORP funding programs.
And what's it again? NCORP?
It's called the National Cancer Institute Community Oncology Research Programs.
Okay.
And they recognize that not all research is done in NCI designated cancer centers. So they kind of want to have real world experience with cancer research in communities like ours and organizations that collaborate together.
Okay.
Can I, excellent discussion. I had a comment and a question, or a couple comments maybe. So one,
Please.
for sure, we can support and facilitate and help with the, mock study section, et cetera, grant prep kind of stuff. And then I don't know if Julie Sokup is still here, but I think you might find some expertise in exercise science at Creighton. I think Eric Bradall is the one that does research on cancer and exercise outcomes.
Correct.
Okay. So I've seen, his work and things he's proposed, and that seems just exactly in line with this. So I think he would be somebody that you could reach out to, you know, the more you get the experts for the different parts of your grant, the better it'll score, right? So I think he would be somebody to bring in. And then I wondered if you talked to a statistician or thought about the scale of this, the power needed for this, and if it would be, you know, only Nebraska or only CHI.
Yeah,
Methodist,
so
I don't know, patients.
yeah,
or-
you know, we serve as the primary referral site for most of Nebraska, surrounding Dakotas and some parts of Iowa and Kansas and Missouri. But we have collaborators, for example, as I mentioned, the Head Neck Cancer Consortium for the Midwest has 6 groups, including University of Minnesota, University of Iowa, Missouri, Avera Group in South Dakota, and Kansas. These are all very motivated people who would partner with us. Additionally, we could take it through the American Head Neck Society and disseminate it through multiple sites across the nation, depending on who all is interested. And there is certainly interest about this because we've been presenting like panels and, you know, holding workshops and those kinds of things when we do our national meetings. So there's certainly interest through survivorship groups within these organizations to do this. But again, most of these are populated by surgical specialists. And therefore their experience is, you know, at risk of being siloed if we don't partner with people in psychiatry and so on and so forth. So that's my hope here.
Yeah, for sure. Okay, so talking about the statistics, which obviously is on here, I think unfortunately the GME symposium is going on right now. Otherwise, I would imagine we probably would have had at least one of our statistician faculty from the Department of Clinical Research on, but that's something for the future. We are like, we've had a great discussion. I don't know if you're, we probably should move on to our next speaker, but if you have one slide, or if you maybe come back and talk about your second idea.
Sure, we can do that. I will show you one slide and then I can come back for the PTH stuff at another time.
Okay.
Essentially, currently we use PTH for deciding when we should stop after doing parathyroidectomy, saying parathyroid hormone levels have receded back to normal, we can stop. That process takes about 25 minutes, and I have to twiddle my thumbs in the operating room before the lab comes back. We've sent the specimen and those kinds of things. I don't need the exact number of PTH. If somebody could tell me that the PTH is less than 40, then I would be done. I know that this is good. And there is parallels to that from for example, these test strips for pregnancy detection, which are basically detecting HCG at a specific threshold. If you're above it, the line shows. If you're below it, it doesn't. Or blood glucometers, which can do a bedside assessment. And if somebody can help me develop that, I have some great clinical applications, and this can be a great innovation and save lots of OR time and OR spending and those kinds of things. So if there are biomedical science people who want to get in touch with me, please do. Thank you.
Okay, we might schedule that for another time and work on finding the right potential partners and get them in the room for your conversation and presentation. But thanks for the preview.
Thank you.
And it looks like a really interesting and exciting project. So.
Perfect. And I apologize that some of my students are presenting research at the GME symposium. So if you guys are okay, I can continue this conversation with the collaborators offline as well, but I may go down and support them if that's okay.
Sure. Thanks for being here.
Thank you.
Okay, well, let's switch gears and turn the recording off and